This patient was referred to me for endodontic retreatment on tooth number 8. According to the patient, this root canal was done 45 years ago when she was 12 years old. There was trauma to these teeth, and according to the patient, half of the crowns broke off, and she got the root canals done 45 years ago. A few months ago, tooth started to hurt, and suddenly she also noticed a swelling right above tooth number 8. And she also mentioned that when she touches the area right under her nose, it's painful. So she went and saw her dentist and was placed on antibiotics. Swelling went away, and patient was referred to me for an apicoectomy. Okay, so now when a dentist only talks to the patient about the apicoectomy option, that means that that dentist needs to study up a little bit, read a few articles, a few endo magazines, maybe Pathways of the Pulp, things like that, because apico is not the only option in this case. Okay, so let's go over the options. So the tooth was percussion sensitive, definitely palpation sensitive, very tender to palpation. Probings were 1 to 2 millimeters all around. So as you can see, tooth is part of an abutment to a bridge here. Okay, prefab metal post. This is how I read my x-ray, so I want you to do the same thing. Start from the top. So you abutment to a bridge, prefab metal post, gutta percha here. You got root resorption here. As you can see, there is root resorption, apical root resorption. And let's look at another angulation. And in this angulation, you can see the large periapical relucency that's associated with tooth number 8. Okay, so let's talk about options now. This is how I talk to my patient about her options for this tooth number 8. One option is extraction. Have your dentist cut the bridge off, take this tooth out, bone graft, dental implant, and a crown. So that's one option. So extraction is definitely an option here for this patient. My job is to go over options with the patient, pros and cons, answer the questions, and then let them decide what they want to do. I'm not going to fall into the trap that them making me decide for them. Option number two would be non-surgical retreatment. Okay, so I would have to go through her bridge, and I always tell the patient, I'm going to have to drill through your bridge. You may need a new bridge. Just assume that you will need a new bridge, because this bridge could get damaged, cracked, could breaks. You will assume you will need a new bridge. And I always tell them, if you need a new bridge, I'm not going to be responsible. Okay? But if I don't tell the patient that, I might be responsible, because if the bridge cracks or breaks, then the patient will say, how come you didn't tell me that would happen? All right? So I always tell the patient, and I always, of course, document it in the patient's chart notes. So non-surgical retreatment, I would have to drill through the bridge, remove the post, and I tell the patient, sometimes this post doesn't want to come out. I'll do my best, but sometimes it doesn't want to come out. So once I remove the post, then I can remove the gutta percha here and redo the root canal. I'll, of course, in this case, place an MTA plug. Why? Because there is root resorption there. Probably the apical diameter will be 50 and more. And also, I want to make my life easier just in case if she needs an apical in a few months down the road. Okay. So that's the other option. And then come back and see me in 6 months after we've redone non-surgically redone the root canal. We'll take some x-rays, compare them to x-rays from today. If this dark shadow is getting smaller, which means healing, bone is regenerating, then that's great. If not, and you still have some symptoms, then we can go ahead and do the apical, and I talk to them about the apical, what the apical is. Okay. Now, what's the third option? The third option would be apical, just going straight to apical. What's the downside of going straight to apical? The downside of going straight to apical is that there is bacteria. We don't just have bacteria here in the apical few millimeters of the canal, because that's where apical addresses. That's the area where apical, that's the limit of apical. It only addresses the bacteria and their byproducts in the apical few millimeters of the canal. But we well know that we have bacteria throughout the entire length of the root canal, not just here. Bacteria and their byproducts. So what can happen is that you do the apical, patient's symptoms go away, everything is great for a few months, maybe a few years, and then patient comes back and this happened again. So going to apical doesn't address all the bacteria and their byproducts that reside within the entire length of the root canal system. They only addresses the apical few millimeters, and you seal it. Even if you seal it with the best material, if you leave bacteria here, everything loses its sealability after a while. It's just a matter of time for the apical seal to get disrupted, and now you have microorganisms, bacteria that you left behind in the space, in the part of the root canal that you could not address with just apical to reinfect. Okay, so that's why I don't like to go to apical right away, because I want to do the non-surgical first, place an MTA plug here, and then if the patient comes back and this area is not healed and patient still has symptoms and I want to do apical, now I know very likely I'm not dealing with microorganisms throughout the length of the root canal. I'm probably dealing with bacteria, the biofilm that's residing outside on the root surface of the tooth. These bacteria we can get rid of with apical, because we go in and we cut the apical few millimeters of the root here, clean all of this out, and then retrofill. So if there are bacteria outside in this area here, apical will get rid of. But I've already redone the root canal non-surgically and very likely gotten rid of all the bacteria and their byproducts in the entire length. Then I spend some time explaining everything to the patient again, answering their questions, and let them decide what they want to do, and then I document. All right. So in this case, this patient decided, she said, well, it makes sense. What you said makes sense. So I want to try the non-surgical endodontic retreatment first. Again, I told the patient, you may need a new bridge. And the patient said, let's just go out and do it. Whatever happens, happens. But this is how you talk to the patient. This is how you educate the patient. And this is considered an informed consent. So patient signs, that's considered informed consent, because you talked about all the treatment options, the risks and benefits, and answer the patient's questions, and patient knows exactly what they have and how it's being treated. All right. So you can't just jump to a treatment without sitting down with the patient and explaining all of this to the patient.